Welcome to Uber School's USMLE Step 1 Pathology Study Guide. I'm Pete, and today we're diving deep into the fascinating world of neoplasia.
And I'm Crash, ready to crash course our way through this crucial topic. Remember, folks, understanding neoplasia is key to acing your USMLE Step 1.
Absolutely, Crash. Let's start with the basics. Neoplasia literally means new growth, but in medical terms, we're talking about abnormal tissue growth that persists even without the original stimulus that triggered it.
Right, you are, Pete. And this abnormal growth can be benign or malignant. Let's break down the characteristics of benign versus malignant tumors, shall we?
Great idea, Crash. Benign tumors are like the well-behaved cousins in the tumor family. They're well-differentiated, meaning they closely resemble their tissue of origin. They have uniform nuclei, low mitotic activity, and often possess a capsule.
Nice analogy, Pete. And on the flip side, malignant tumors are like the rebellious teenagers of the cell world. They show poor differentiation, have pleomorphic, varied-shaped nuclei, high mitotic rates, and lack a defined capsule.
Exactly, Crash. But the differences don't stop at appearance. Functionally, benign tumors may cause latial effects due to their size, but they generally respect tissue boundaries. Malignant tumors, however, are the real troublemakers.
You got that right, Pete. Malignant tumors invade surrounding tissues and can spread to distant sites, a process we call metastasis. This ability to metastasize is really what sets malignant tumors apart and makes them so dangerous.
Absolutely crucial point, Crash. Now let's hit our listeners with a quick USMLE-style question to reinforce these concepts.
Bring it on, Pete.
All right, here we go. A 45-year-old woman presents with a painless, mobile mass in her breast. A biopsy is performed, and histological examination reveals a well-circumscribed lesion with uniform cells and a fibrous capsule. Which of the following is the most likely diagnosis?
Ooh, good one, Pete. Let's break this down for our listeners. We've got a well-circumscribed lesion with uniform cells and a fibrous capsule. These are all hallmarks of what type of tumor, folks?
That's right, Crash. These are classic features of a benign tumor. In this case, given the location and characteristics, the most likely diagnosis is a fibroadenoma of the breast, a common benign breast tumor.
Spot on, Pete. And remember, future doctors, fibroadenomas are typically found in young women and are often called breast mice because they're mobile under the skin.
Great mnemonic, Crash. Now let's move on to carcinogenesis. This is a crucial concept for understanding how normal cells transform into cancer cells.
Ah, the dark side of cellular evolution. Carcinogenesis is a multi-step process, right, Pete?
Absolutely, Crash. It involves three main stages: initiation, promotion, and progression. Initiation is when a cell sustains DNA damage, often due to carcinogens. Promotion involves the clonal expansion of initiated cells, and progression is when these cells acquire more mutations and malignant characteristics.
And let's not forget the role of genetic alterations in this process. We're talking about point mutations, chromosomal translocations, gene amplifications, and even epigenetic changes.
Absolutely crucial, Crash. These genetic alterations can affect proto-oncogenes, tumor suppressor genes, and DNA repair genes, leading to the hallmarks of cancer we'll discuss later.
Speaking of carcinogens, Pete, did I ever tell you about my old buddy Marcus Cooper?
Oh boy, here we go. What's the story this time, Crash?
Well, Marcus once claimed he could identify carcinogens just by smell. Said he developed the ability after accidentally inhaling fumes from a chemical spill at a research lab. He'd walk into a room and shout, "Carcinogen alert!" if he detected anything suspicious.
Crash, I'm pretty sure that's not how carcinogen detection works, but it does bring up an important point about chemical carcinogens. Many components of tobacco smoke, for instance, are potent carcinogens that can directly damage DNA.
Right, you are, Pete. And let's not forget about radiation carcinogenesis. It can cause direct DNA damage and generate those pesky free radicals.
Excellent point, Crash. And we can't overlook viral carcinogenesis. Viruses like HPV can cause cancer through mechanisms like insertional mutagenesis and expression of viral oncoproteins.
True that, Pete. Now, how about we hit our listeners with another USMLE-style question to keep them on their toes?
Great idea, Crash. Here's one. A 55-year-old man with a 30-pack year smoking history is diagnosed with lung cancer. Which of the following carcinogens in tobacco smoke is most directly associated with DNA adduct formation?
Ooh, tricky one, Pete. Listeners, think about the components of tobacco smoke and their mechanisms of action. Which one forms covalent bonds with DNA?
The answer here is benzo, a pyrene crash. It's a polycyclic aromatic hydrocarbon found in tobacco smoke that forms DNA adducts, leading to mutations and potentially cancer.
Exactly, Pete. And remember, folks, DNA adducts are covalent modifications of DNA that can lead to mutations if not repaired correctly. It's a key mechanism in chemical carcinogenesis.
Great explanation, Crash. Now let's move on to tumor grading and staging. These are crucial concepts for understanding prognosis and guiding treatment decisions.
The report card of tumors, if you will. Grading is all about how the cancer cells look under the microscope, right, Pete?
That's right, Crash. Tumor grading assesses the degree of differentiation and cellular atypia. The more abnormal and undifferentiated the cells look, the higher the grade and typically the more aggressive the tumor.
And a great example of this is the Gleason score for prostate cancer. It evaluates the glandular architecture and assigns a score from 1 to 5 for the two most common patterns seen.
Excellent point, Crash. The Gleason score is a sum of these two numbers, ranging from 2 to 10, with higher scores indicating more aggressive cancer.
Now, staging is a whole different ballgame, right, Pete? It's more about how far the cancer has spread.
Exactly, Crash. The most commonly used staging system is the TMM system. T stands for the extent of the primary tumor, N for involvement of regional lymph nodes, and M for the presence of distant metastases.
And each of these gets a number, right? Like T1, N0, M0?
That's right, Crash. The numbers indicate the severity. For example, T1 might be a small localized tumor, while T4 could be a tumor that's invaded adjacent structures. N0 means no lymph node involvement, while N3 might indicate extensive lymph node metastases.
And M is pretty straightforward, minus M0 for no distant metastases, M1 if there are distant metastases.
Spot on, Crash. Now, let's challenge our listeners with another USMLE style question.
Fire away, Pete.
A 60-year-old man is diagnosed with colon cancer. The tumor has grown through the muscularis propria and to pericolorectal tissues, but has not penetrated the surface of the visceral peritoneum. 2 out of 15 regional lymph nodes are positive for metastatic disease. There is no evidence of distant metastases. What is the correct TNM stage for this patient's cancer?
Ooh, this is a good one, Pete. Listeners, think about what each component of TNM represents and what the description tells us about each.
The correct answer here is T3N1M0, crash. The tumor has grown through the muscularis propria, but not through the visceral peritoneum, which is T3. There are positive lymph nodes, but less than 4, which is N1, and there are no distant metastases, so M0.
Excellent breakdown, Pete. And remember, folks, staging is crucial for determining prognosis and guiding treatment decisions. It's not just about memorizing numbers, but understanding what they mean for the patient.
Absolutely, Crash. Now, let's move on to a topic that's often the most feared aspect of cancer, metastasis.
Ah, yes, the great escape artists of the tumor world. Metastasis is quite a complex process, isn't it, Pete?
It certainly is, Crash. Metastasis involves several steps: invasion of the basement membrane, intravasation into blood or lymph vessels, survival in circulation, extravasation at a distant site, and colonization.
Sounds like quite the journey for a cancer cell, and they can travel different routes, right?
That's right, Crash. Tumors can spread via hematogenous, blood, lymphatic, or transoolomic routes. The route often depends on the type and location of the primary tumor.
And some cancers have favorite vacation spots, don't they, Pete? Like how prostate cancer loves to set up shop in the bones.
Great analogy, Crash. Yes, certain cancers show organ-specific metastatic patterns. Prostate cancer's predilection for bone is a classic example. Lung cancer often metastasizes to the brain, liver, and adrenal glands.
And don't forget about colorectal cancer, Pete. It often takes a trip to the liver via the portal vein.
Excellent point, Crash. Now, let's delve into the molecular mechanisms of metastasis. One crucial process is epithelial mesenchymal transition, or EMT.
The cellular identity crisis. EMT is when epithelial cells lose their cell adhesion and gain migratory properties, right?
Exactly, Crash. EMT involves the loss of E-cadherin expression and the gain of mesenchymal markers like vimentin. This allows cancer cells to break away from the primary tumor and invade surrounding tissues.
And once they've broken free, They need tools to cut through the extracellular matrix, don't they, Pete?
Right, you are, Crash. That's where matrix metalloproteinases, or MMPs, come in. These enzymes can degrade various components of the extracellular matrix, paving the way for cancer cell invasion and metastasis.
It's like the cancer cells have their own personal demolition crew. Now, how about we test our listeners' understanding with another USMLE-style question?
Great idea, Crash. Here's one. A 65-year-old man with a history of prostate cancer presents with severe back pain. A bone scan reveals multiple areas of increased uptake in the vertebrae and pelvis. Which of the following is the most likely mechanism for the preferential metastasis of prostate cancer to bone?
Ooh, this is a good one, Pete. Listeners, think about the unique properties of bone issue and how cancer cells might interact with it.
The correct answer here is the interaction between CXCR4 on prostate cancer cells and CXCL12 SDF1 produced by bone marrow stromal cells. This chemokine receptor interaction helps guide prostate cancer cells to the bone and supports their survival and proliferation in the bone microenvironment.
Fascinating stuff, Pete. It's like the bone is sending out a homing beacon for these cancer cells.
Great analogy, Crash. Now let's shift gears and talk about paraneoplastic syndromes. These are the sneaky side effects of cancer that aren't directly related to tumor mass or metastasis.
Ah, the cancer's way of causing trouble from afar. These can be quite diverse, can't they, Pete?
They certainly can, Crash. Paraneoplastic syndromes can affect various systems in the body. Let's start with endocrine syndromes. A classic example is Cushing's syndrome from ectopic ACTH production, often seen in small cell lung cancer.
Right, and there are neurological syndromes too, aren't there? Like Lambert-Eaton myasthenic syndrome, which is also often associated with small cell lung cancer.
Excellent example, Crash. Lambert-Eaton is caused by antibodies against voltage-gated calcium channels, leading to muscle weakness. And let's not forget about hematological syndromes like thrombophlebitis migrans in pancreatic cancer.
Ah, yes, Trousseau's syndrome, named after the French physician who, ironically, diagnosed it in himself before discovering he had gastric cancer.
Great historical tidbit, Crash. There are also dermatological manifestations of paraneoplastic syndromes. Acanthosis nigricans, for instance, can be a sign of internal malignancy, often gastric cancer.
And don't forget about that classic board favorite, Pete, hypertrophic pulmonary osteoarthropathy.
Oh yes, good catch, Crash. That's often associated with lung cancer and causes clubbing of fingers and toes, along with painful swelling of joints. Now, how about we test our listeners with another USMLE style question?
Bring it on, Pete.
All right, here we go. A 60-year-old man with a 40-pack year smoking history presents with worsening muscle weakness, especially when climbing stairs or reaching for objects above his head. His symptoms improve with repeated use of the affected muscles. Which of the following is the most likely diagnosis?
Oh, this is a classic, Pete. Listeners, think about the paraneoplastic syndromes we just discussed, especially those associated with lung cancer.
The correct answer here is Lambert-Eaton myasthenic syndrome, CRASH. The key clues are the smoking history, which puts the patient at risk for small cell lung cancer, and the pattern of muscle weakness that improves with repeated use.
Spot on, Pete. And remember, folks, Lambert-Eaton is caused by antibodies against voltage-gated calcium channels. That's why the weakness improves with repeated use. It allows more calcium to accumulate in the presynaptic terminal.
Excellent explanation, Crash. Now let's dive into oncogenes and tumor suppressor genes. These are key players in the molecular basis of cancer.
Ah, the yin and yang of cancer genetics. Oncogenes are the accelerators, while tumor suppressor genes are the brakes, right, Pete?
That's a great analogy, Crash. Proto-oncogenes are normal genes that, when mutated or overexpressed, become oncogenes promoting cancer. Examples include RAS, MYC, and BCRABL.
And these oncogenes can be activated in different ways, can't they, Pete?
Absolutely, Crash. Activation mechanisms include point mutations, chromosomal translocations, and gene amplifications. For instance, the BCRABL fusion gene in chronic myeloid leukemia is created by a translocation between chromosomes 9 and 22.
Ah, the infamous Philadelphia chromosome. And what about tumor suppressor genes, Pete? They work a bit differently, don't they?
They do indeed, Crash. Tumor suppressor genes like P53, RB, and BRCA normally inhibit cell proliferation or promote apoptosis. Unlike oncogenes, they typically require inactivation of both alleles to lose their function.
Right, the old two-hit hypothesis is by Knudsen. First hit takes out one allele, second hit takes out the other.
Exactly, Crash. And it's worth noting that some tumor suppressor genes like P53 can act in a dominant negative fashion. This means that a mutation in one allele can interfere with the function of the normal allele.
Fascinating stuff, Pete. And don't forget about DNA repair genes and cell cycle regulators. They're like the quality control team in the cell factory.
Great point, Crash. Genes like BRCA1 and BRCA2 are crucial for DNA repair, and their inactivation can lead to genomic instability and cancer. Now, how about we challenge our listeners with another USMLE-style question?
Fire away, Pete.
A 25-year-old woman with a family history of breast cancer undergoes genetic testing. She is found to have a germline mutation in the BRCA1 gene. Which of the following best describes the mechanism by which this mutation increases her cancer risk?
Ooh, this is a good one, Pete. Listeners, think about the function of BRCA1 and how its loss might affect the cell.
The correct answer here is impaired DNA double-strand break repair, CRASH. BRCA1 is crucial for homologous recombination repair of DNA double-strand breaks. When it's mutated, cells accumulate DNA damage, leading to genomic instability and increased cancer risk.
Excellent explanation, Pete. And remember, folks, BRCA1 mutations don't just increase breast cancer risk. They also raise the risk of ovarian cancer, among others.
Great point, Crash. Now, let's wrap up with a discussion on the hallmarks of cancer, as described by Hanahan and Weinberg. This framework really ties together everything we've talked about.
Ah, the 10 commandments of cancer biology. Or was it 8? 10. How many are there now, Pete?
Initially, there were 6, Crash, but it's been expanded to 8 core hallmarks and 2 enabling characteristics. Let's go through them. Sustained proliferative signaling, evading growth suppressors, resisting cell death, enabling replicative immortality, inducing angiogenesis, activating invasion and metastasis, reprogramming energy metabolism, and evading immune destruction.
And the 2 enabling characteristics?
Those would be genome instability and mutation and tumor-promoting inflammation. Now let's break these down a bit. Sustained proliferative signaling often involves dysregulation of growth factor signaling pathways.
Right, like the Rees-Raff-Meckerk cascade. Mutations in RAS are found in a huge percentage of human cancers.
Excellent example, CRASH. And evading growth suppressors often involves inactivation of tumor suppressor genes like RB and P53.
And resisting cell death? That's where our friend BCL2 comes in, right, Pete?
Spot on, CRASH. Overexpression of anti-apoptotic proteins like BCL2 is a common way cancer cells avoid programmed cell death. Now, enabling replicative immortality often involves maintaining telomeres, usually through activation of telomerase.
Ah, yes, the cellular fountain of youth. And angiogenesis is crucial for tumor growth beyond 1 to 2 millimeters, isn't it?
Absolutely, Crash. Vascular endothelial growth factor, VEGF, is a key player here, often upregulated in response to tumor hypoxia through HIF-1 alpha activation.
And we've already talked about invasion and metastasis. What about reprogramming energy metabolism, Pat?
Great question, Crash. This refers to the Warburg effect, where cancer cells prefer glycolysis even in the presence of oxygen. It's less efficient, but allows for rapid production of building blocks for new cells.
Fascinating stuff, Pete. And evading immune destruction? That's a hot topic in cancer research these days, isn't it?
It certainly is. Crash. Cancer cells can evade the immune system in various ways, like expressing PD-L1 to inhibit T-cell responses. Understanding this has led to groundbreaking immunotherapies.
Amazing how all these hallmarks come together to create the perfect storm that is cancer. How about we wrap up with one last USMLE-style question, Pete?
Great idea, Crash. Here's one. A new drug is developed that inhibits vascular endothelial growth factor, VEGF. Which of the following hallmarks of cancer is this drug primarily targeting?
Ooh, this is a good one, Pete. Listeners, think about what VEGF does and how it contributes to cancer growth.
The correct answer here is inducing angiogenesis, CRASH. VEGF is a crucial factor in promoting the growth of new blood vessels to supply the tumor with oxygen and nutrients. By inhibiting VEGF, we're targeting the tumor's ability to induce angiogenesis.
Spot on, Pete. And this isn't just theoretical. Drugs like bevacizumab, Avastin, that target VEGF are used in the treatment of various cancers.
Excellent point, Crash. And that brings us to the end of our deep dive into neoplasia. Remember, understanding these concepts is crucial not just for acing your USMLE Step 1, but for your future practice as physicians.
Absolutely, Pete. And don't forget, folks, this has been an Uber School production. We're here to help you succeed.
Thanks for joining us, everyone. Keep studying, stay curious, and we'll see you in the next episode.